main delay in some people getting here we'll take advantage of the time interval just to let people know that within the next week, those of you with really good eyes can see and might remember that about 2 weeks ago, Dr. Barbieri was sporting a button, asked me whether I have washed my hands, and we have ordered buttons for the physicians, the nurses, the entire staff. This came actually, the thought about this came before the flu epidemic. Various people in the department sit on Department of Public Health committees and came back and said this very simple request, first of all, shows our commitment to cleanliness and diminishing of infections, and releases the patients from their reticence in asking us. I've tried this on my own patients, and it doesn't completely release them from that reticence, but it is a self-stimulating sign. So I would hope that when we finally get enough buttons for everyone, that you will wear your button proudly, Ryan, and equally proudly wash your hands. All right. So, Dr. Robertson needs no introduction because she is of our program, and she hopefully will stay with our program. But in reviewing the little fellows' bios that came out from the Commonwealth Fellowship, I was reminded that she was once a chemist, and trying to really understand what she did before she switched, I just happened to ask Audra, so what did you discover? You were a chemist. That's what chemists do. They discover things. And what came back was this type of wisdom that one hopes one hears from one's children. And having known Audra and looking upon her as just one of the many daughters that I never really had, what she said, well, I'll tell you what, why don't you start, because it came out so much better from you. And why don't you start to why you switched from yes, baby? Why you switched from petrochemistry to medicine? Because I don't think there could be any nicer introduction for Audra than her own statement of why she is who she is today. So come on up and tell us.
So, why did I change from petrochemical industry? So I graduated from Texas A&M University as a chemistry major and loved it. Thought it was interesting. Was that kid that grew up with a chemistry set in my mom's kitchen, blowing up things, making things, creating things. So it was fun. And so we mostly dabbled in lipid chemistry, and what we made with these oil water emulsifiers that helped to separate any product that Exxon made from water so that we could collect it back. So hence, whenever we had some sort of spill or release something from a tank into the Gulf of Mexico, we had the ability to get that back by separating. And so I said that the reason why I decided to change my career, because at the time I was still in my younger 20s, which was nice. I thought, there were a lot of things happening in the world, one of them being Columbine, actually, and so many things that you feel that as a part of your community, you want to be a benefit to your community. And so I thought, my career is great and it's fun and I really enjoyed it, but I really wanted to do something different where I would benefit my community more so than financially benefiting the company that I was working for at the time. So I decided to get a doctorate, and in doing so, I decided for a medical doctorate and applied to medical school. Being a chemistry major, it wasn't too hard because I'd already had all the core courses, so it was nice. But what am I doing here today talking Grand Rounds? I'm so excited that Dr. Barbieri asked me to give Grand Rounds today. And so this will explain what I do most of the time when the residents sometimes ask, well, what do you do when you're not here? And I'll talk about that today. So after finishing medical school in San Antonio and then residency program here, I went to the School of Public Health and did a one-year fellowship, non-clinical fellowship in health policy and health disparities. And in doing so, I sort of carved out my future for what I thought I wanted to do in medicine, which was a combination of how do you help your community and be a part of your community while at the same time delivering care and being the person that truly delivers public health. Because oftentimes in medicine, we may deliver medical care, but we don't feel like we're truly offering that public health component that we'd like to offer. So in my spare time, I've been working with the Brigham Women's Hospital Center for Community Health and Health Equity, designing and getting off the ground the Birth Equity Initiative. So this is an introduction to the department and to you guys about the Birth Equity Initiative, which is very new. And this is for the elimination of disparities and infant mortality in Boston. Our logo and our interest is about health equity. So we appreciate the phrase that one of our colleagues designed, which is a lifetime of health equity begins at birth. So did you guys know, among the residents, because I want to be very interactive, so you're not going to get a chance to be shy, you'll have to speak up today, okay? That babies born to black women in Boston are nearly 4 times as likely to die in the first year of life as babies born to white women in this city. Did you guys know that? Did you know that there was a disparity in infant mortality? That said, what were we taught? Case-based, evidence-based, and interactive, of course. So let's take a case. And this case is not going to be unfamiliar to anybody, so I didn't put very many specifics because everybody has seen a case like this, and everyone can pretty much relate. So my chief year, we had a healthy 34-year-old African-American woman who presented to Brigham Women's Hospital. So I say a teaching hospital because this could occur in a lot of different places because as a metropolitan city, we're not very different from other places. With bleeding and abdominal pelvic pain at 27 weeks gestation. How often have we seen that? So despite current medical intervention, she delivered a 3-pound, 10-ounce boy prematurely. He lived 64 days, and the mom was emotionally devastated. So how many of us have had the opportunity to round on our patients with the purple leaf on the door that they've either had the baby die in the hospital or subsequently we've seen moms that deliver babies that the baby stayed in the NICU, and then we've seen them postpartum and the baby did not live. And the question is, well, what makes her more susceptible to her baby dying than anybody else? Well, infant mortality, though, is a significant indicator of the community's health and social welfare. This is something that I learned while in public health school. It's something that's used often as a metric to determine how healthy a community is. So they measure that by an infant mortality rate. So that said, infant mortality is measured across the world to determine this. And any place that you've noticed that there are higher infant mortality rates, they're usually the developing nations. And even among developed nations, infant mortality rates differ in different parts of communities. So that gives us some sort of indication as to how healthy that community is. So the Brigham and Women's Center for Community Health and Health Equity is the coordinating department within the Brigham that benefits the community through health equity programs. It was established in 1991 under Judy Ann Bigby, but in 1997 began to expand away from only discussing health of infants, mothers, and families, but also bringing in health disparities and trying to address health inequities. And so the mission now, as it's been rewritten, is to advance systems of care and community health strategies to eliminate health disparities and elevate the health status of communities served by Brigham Women's Hospital. So this is the department within the Brigham that's whole purpose is to design programs to help improve the community's health, and that's fantastic. So as an obstetrician gynecologist, as a generalist who loves being a general OB/GYN, how do we begin to help the women in the communities that surround the Brigham improve their birth outcomes? So let's talk about today defining the disparity. We'll talk about a few definitions. We'll review some state, national, and local data to identify the disparity. So that's the first thing you want to do in health disparities work, whether the health outcome be infant mortality or otherwise. You want to define the disparity with data and see where the disparity exists. Understanding the cause of disparity, so we'll talk about preterm birth, differences in risk versus care, and we'll talk about this term stress and allostatic load. Are you guys familiar with allostatic load and allostasis? Good, so we'll learn a little more today. Addressing the disparity, we'll talk about identifying promising practices, These are practices such as, let's use an example. If someone employs a method such as a patient navigator system to help improve the utilization of mammography among women that live in a certain neighborhood who may have higher rates of breast cancer that were undetected, then if it's proven to help reduce the burden of breast cancer or improve early detection, then that's a best practice because it's something that we designed in the healthcare system that has been shown to help improve a health outcome. If it's designed to help improve a health outcome but it hasn't been validated or replicated as a model that is truly shown to be beneficial, but in the early stages of being shown to be beneficial, then it's also a promising practice. So those are what we're going to look for, talk about later on. And then creating the Birth Equity Initiative and how do you apply a health equity matrix. So this health equity matrix is something that I designed to help package the programs so people can begin to understand every level of care and intervention. And then we'll do a discussion. So let's begin by defining the disparity. So let's talk about a few definitions. So looking at me and not at the screen for the residents. Okay, ready? So let's talk about fetal death and fetal mortality. Someone tell me, what is fetal mortality? Come on, quicker. Yeah, so it's just basically in utero death of a fetus at any gestational age. But what do we usually see it reported as? When we think of fetal death, we think of what? What gestational age? Yeah, usually it's reported to help us beyond 20 weeks because anything less than that we usually report as spontaneous abortion. But that's still considered a fetal death, so just to talk about that. When you see it reported at times in the two reporting bodies that you'll often look towards, and that's DHHS, so Department of Health and Human Services, has the National Center for Health Statistics, so NCHS. You'll look at data there because states are somewhat required, to send their data back to NCHS. The CDC also has a lot of data, so you've seen their web pages possibly that have the perinatal health outcomes and different reports there. And that data usually is gotten from, they get that from the National Center for Health Statistics. So these are the definitions that they use, and when they talk about early fetal death, they talk about 20 to 28 weeks and late is 28 to 40 weeks, okay? So this is just giving us some baseline definitions for the top. Perinatal death, okay? Again, looking at me, not the screen. Perinatal death. Okay, Ryan, let's go for it.
Within a certain time period after birth.
Yeah, so it's actually reported that there's two definitions. It's death in utero or even after birth to 7 days, okay? So in some places they define it as anywhere from 28 weeks to 7 days, and some places expand that definition to say 20 weeks up to 28 days. So there's the neonatal death period. So neonatal death is death in the first 28 days of life. So depending on the definition is how we report that, and that matters because when you do international comparisons, you want to use the definition between 28 weeks and 7 days of life because there's differences in reporting of fetal death prior to 28 weeks. So that's important, okay? So when you're talking about the data, you want to be able to compare apples to apples, okay? And then infant death. Okay, Vicki.
Death in the first year.
Okay, and there's two periods divided in neonatal and postnatal. Neonatal, again, is death in the first month, first 28 days of life, and then postnatal is anything from 28 days of life to 1 year of life. Okay, so now that we've got the data, let's look at how we compare internationally. So the United States, where do you see it down here? Way down here at the bottom. So this is the most recent ranking of nations that have populations of greater than 2.5 million. Where do we rank? Infant mortality via deaths per 1,000 live births. We're down here at 24th. We have an infant mortality rate of double that of these top few countries. Okay, so even when you take it all together, the United States has what I would consider a dismal rate given the wealth of this country and given the health care that the dollars we spend towards health. But we've done well. We've seen a decline in infant mortality rate in the United States, and I took 1915 to 1997. This is the end peak. You'll see another one sometimes reported if you look at Health of Boston reports and Massachusetts data that shows it all the way from 1815 to approximately present. And so it's declined. So even though we've declined, we're still at a higher rate than where we probably should be. And then in looking at the decline, we also see that the decline has happened for all races when you break this down by race. You've seen that the black race, the white race, all races together had a decline. But you see this gap here? I don't think I have the pointer. Is it on the front? Put it down. Okay, so this gap, it's pretty persistently the same, doesn't it? So that's the disparity that we're talking about. That's that difference in health outcomes that we wanted to close this gap. So that's our goal, is to close this gap. Because why is it that when we're in an OB clinic and an African American woman, or black, I should say black, because somebody who identifies from any particular country, whether it be West Africa or the Caribbean area, or born in America, why do they walk through the door and have a 4 times the rate chance of having their baby die in the first year of life just by race alone than somebody else? So this isn't only about black and white. Blacks, Native Americans, and Puerto Ricans all have the most elevated rates. So as you can see, I just went across the decade between 1995 and 2004. They have the highest rates. African Americans or blacks and Puerto Ricans for usually the same reason, death in neonatal period, and Native Americans usually due to postnatal death. But for the purpose of this talk and for this, and in most talks when you see about infant mortality, they'll compare that to the rate for white women. So you can see that that disparity has been persistent. So this is a little bit of redundant data. And who has heard of the Hispanic paradox? Anyone heard that phrase? Okay, so mostly on this side, so they've got you beat so far. We'll pick up the pace on that side. So the Hispanic paradox says that for some reason in this country, those of not only Latino descent, because we're not talking about Puerto Rican, Cuban, and South Central American, we're talking about Mexican American. Hispanics in this country have better birth outcomes than most other races. And so why is that when they have about the same socioeconomic status, if not worse, than other groups? So that's being studied currently in public health research, because people want to understand what is it about that Hispanic group, particularly Mexican Americans, that they have a lower infant death rate and lower rates of premature birth. So this is another pictorial again to just show that in the United States, in Massachusetts, and in Boston, there's a disparity. And so the disparity is unique to our city, but at the same time it's a little bit higher, because here's about 2.4 times the rate, 2.6 times the rate. Here we're about 3.7 times the rate. So why is that? Healthy People 2010 is our nation's health promotion system set down by the U.S. Surgeon General. And he says we should have an infant mortality rate of 4.5. Have we reached that? Yeah, you have for certain sectors of the population and for other races, but you haven't reached it for the African American race. Overall, for Massachusetts, the current rate right now hits about 5.2 when you add everybody in together. So we haven't reached it overall. But you're doing it for some sections of the population, so we've just got to catch up in other places. There's one more, just to keep driving home this point. There is a disparity between the infant death. This yellow line represents African American infant death rate in Boston over a decade, and here are other races. And our goal in this program, the Birth Equity Initiative, is to close that gap. So let's now begin to understand the cause of the disparity. So again, infant death is death in the first year of life divided between the neonatal period and the postnatal period. So the excess deaths that we see that cause the disparity are usually deaths due to premature birth and disorders of low birth weight. So when you look at the CDC's rankings of infant death, the number one cause is, for the residents, imagine. The number one cause for all races is congenital defects, so anomalies. The number two cause would be disorders of premature birth and low birth weight. Now, when you break that down by race, for African American women, for black women, the number one cause is disorders of low birth weight and prematurity. Okay, so we noticed that 80% or more of those excess deaths are due to deaths in the neonatal period. So that's what our focus is going to be. So why are these women delivering prematurely? Again, looking at these rates here. This is total rates of preterm birth related. So now we've moved away from talking only about infant death, but looking at the rates of preterm birth, and this is also NCHS and CDC data. So here's the total, and this is just going in order so that you can see that African Americans suffer greatest of total premature births as well as premature related deaths, and then down the line. So blacks, Puerto Ricans, Native Americans. So you can tell that they're not dying here because they have a high rate of prematurity, but they're not mostly dying because of prematurity. Okay, there's mostly postnatal death. But here it is true for African American women. So let's try to work through a cascade of why that is. Okay, so that begins with what? We're going to do literature review. So that's what I did for a long time. I searched the literature. I tried to look at what is it out there that explains why more African American women have disorders of premature birth and low birth weight at rates higher than other women. So we looked at it in terms of differences in risk versus differences in care. And this is the work of a few people who were here at Brigham Women's, not Brigham Women's Hospital, but in the Children's Hospital area before, who tried to decipher this out because they were taking care of these neonates. And a lot of the decline in the infant death rate has been due to improvements in neonatal care that's been given. But they wanted to try to understand what is the difference in the rates. Is it because that moms are higher risk, or these babies are born to moms at higher risk, or is it because we're giving different care to these infants? So in looking at some data, Collins and David in New England Journal in 1997, they examined this in terms of racial disparities of birth outcomes and looking at race as an independent factor. And what they thought was, okay, if you took the groups, you took African-born blacks, you took African Americans born in the U.S., and white women. If there was a gene, a birth weight gene that said black women just had babies that were born smaller, then you would think that someone who was more purely African, not intermixed with other races, would have the smallest birth weight. And then a Caucasian woman in America would have the highest birth weight. But that wasn't the case. Birth weights between West African women and white women in this country were about equivalent. Now, when a woman was born in the United States, so they're second-generation offspring of these women that were coming from West Africa were here, their birth weights decreased. So there was something about being in America, being born in America, that changed that. They also looked at it in terms of education, looking at race as an independent risk factor. And they said, okay, what about when you take all these African American women, so women who were born on American soil, who were black, and compared them to white women who were born in America, and you looked at their education? Because we know oftentimes that when it comes to social determinants of health, education is something that helps to mediate, and it brings some equality to the outcomes. But did that happen here? So when you took the most educated women, which means their incomes would probably also be higher, then were they very different? And you still had an odds ratio of 2.9, that their birth weight would be smaller. So what is that? Why does that happen? So going back to our risk diagram, is it genes or is it environment? So genetically, do you think it's genes? Is race a genetic construct? What is it? Very much a social construct. And an interesting person that gave a lecture, because I'm black, and so I was born thinking I'm black. It's a racial thing. It's a genetic thing. Everybody in my family's black, so we're all coming from the same gene pool. It's genetic. And the Human Genome Project actually has shown us that race is not a genetic construct. That's been something that's been able to show that we actually, among one racial group, are more genetically different than between groups. So I was in a lecture in the School of Public Health where Kamara Jones was discussing race, and she is someone who's of mixed race. And she explained that in America she's considered black, but if she goes to Brazil, she's considered white. So it's very different. So race is something that's assigned to you at birth. That's something that you identify within a group and others identify you within a group. And that has something to do with our health outcomes and the way we understand that as a person. So people have sought to understand that in a way, and looking at that in terms of birth outcomes to look at the environment. So we think about social determinants of health. So Ebony, when we talk about social determinants of health, what are some of the terms that we think about in public health?
Social determinants of health?
Yeah. I got something on here.
Oh, thank you. Educational status,
yeah.
Economic status, I guess like demographics, things like where you live in the community.
Yeah, demographics is important. So where you live in a community, what environmental pollution you may be exposed to, and those pollutions don't just mean the chemicals that I made. It could be things like noise pollution, fear, safety, etc., in the environment that you live in. Things that can cause a certain level of psychosocial stress. So in causing that psychosocial stress, we looked at different things. And so we saw with David and Collins information that looking at the environment was important. We looked at their income levels. We looked at their education levels. We didn't see a difference. Race was an independent risk factor there alone. So we began to look at what is it about who they are in this country that explains it. So a lot of the research has come to explaining the risk of psychosocial stress. So this is not just stress meaning you've had a bad day. This is the stress related to the life that you live that then turns into something biochemical. So we're talking about a pathway. We're talking about a cortisol pathway that affects brain development of the person, potentially of your fetus when you're pregnant, okay? So when we started to look at stress, we understand that of the pathways for premature birth, let's talk about some because this is important for the residents, especially in the chief class, since they've got boards coming up. So let's talk about some pathways of premature birth. One of them I'll throw out. So since on Friday mornings I do mini SPOB with the twins, so uterine stretch is one of the pathways that we talk about. What else? So we had Dr. Lockwood come and talk about this one with us. So we talk about clotting diseases, etc. So clotting pathways. What are some other ones? So you have uterine anomalies, etc. Leading to infection. Infection being a final common pathway, okay? So we've talked about a few of these, and we've had lots of grand rounds that sort of begin to talk about the theory. But in the end, what are we saying? We really don't know exactly the cause in every situation, but we have some theories as what those causes are, whether it be decidual hemorrhage, whether it be clotting pathways, whether it be a stress pathway, etc. In the end, the final common pathway is that pathway of infection, okay? That change, and whether that infection that occurs that we think is there, is that due to changes in your neuroendocrine system that reduces a mother's immune functioning so that now there's more likelihood and susceptibility for an infection? Is it just simply an amplification of your immune inflammatory pathway that's happening? So these are some things that people are studying right now, because in African American women, we want to coin it that the literature says that it's a stress pathway leading to that final common pathway of something happening in a neuroendocrine system, immune infection, inflammatory system that's leading to this premature birth. But we don't understand it completely. That said, what we do know is that there is a generational effect. So for these women that are African American or black that are born on U.S. soil, that their next generation is most likely to have a premature birth as well, and so on and so forth. So why is that? So we wanted to understand this in terms of the biochemistry as well as the generational effect that we see. And the other interesting point that comes up is the affective bias. So what is the affective bias or discrimination in our society that might lead towards these poor health outcomes in these patient populations? And then we'll get to discussing allostasis. So homeostasis. Okay, come on. Someone give me a definition of homeostasis, really quick and simple. Yeah, it's a balance. It's the optimal set point, right, of any functioning physiologic system in your body. So whether that be your cardiovascular system, your respiratory system, your renal system, what is that optimal set point? It's homeostasis. So we think we got that in about the 8th grade biology. That was a word that came up. Now, allostasis, where was that? Now, actually, I have to admit, I was like, allostasis. Geez, I went to medical school, I don't remember this word. Allostasis is that combination of all the physiologic responses in your body working together to achieve that optimal set point. So when you think of allostasis, you think of a physiologic response, and let's talk about stress. We think of a fight or flight response. When you see a stress, your physiological systems, they amp up, and then when that stress or that inciting factor is gone, you come back down to a baseline recovery. So this would be considered your allostatic point, okay? So allostasis is just a general concept. So in a fight or flight response, we have increased cardiac output, increased available glucose, enhanced immune system functioning, growth of neurons. That's that system that we have so that we can get away from danger, correct? Now, when we're not talking about lions and tigers and bears, when we're talking about just having a stress in our life, that's still the same pathway that we go through our parasympathetic systems and our sympathetic pathways, okay? That said, when you think of chronic stress, so the stress we're talking about in these groups of people that are having these poor birth outcomes, as well as poor cardiovascular outcomes, poor endocrine outcomes such as diabetes, other infection inflammatory pathway outcomes, neurologic outcomes such as stroke. When we think of that, we're talking about chronic stress. So now we're talking about a physiologic response that's amped up and there's no recovery. And now you have these other problems. So in addition to this, what we're going to add, or what has been added in the concept of talking with Michael Liu and others who are current researchers in this area, is that this allostatic load, this chronic stress, is likely the cause of what's happening with these groups of women and with these poor birth outcomes. Because we are starting to study that in other populations of African Americans and Hispanics in terms of hypertension, diabetes, stroke, etc., that there's this chronic stress response, that your body's system, your allostatic system, for returning to a normal homeostatic set point never recovers. It's constantly at that level of functioning. And when you have that, you basically are putting this wear and tear on your body. Now, this is theory, but this is the going theory that the literature is sort of pointing towards now because the other evidence issues that we've brought up, such as whether this is purely genetic or whether this is purely based on other social determinants, those are being sort of ruled out to say that it's more a situation, an issue of allostatic load within these communities. So, Michael Liu, who's at UCLA, suggests that we take what we call a life course approach. That right now, when do we mostly intervene to try to help improve birth outcome? During pregnancy, so during prenatal care. And is that the most appropriate time to do that? So in thinking about the life course approach, we view life not in stages but as an integrated continuum. So let's talk about medicine. So I'm going to digress for a second and say that I remember coming into medicine and having a course in my very first year of medical school that told us that we moved away from a paradigm of germ theory, that all of medicine in the 1800s was about getting some medicine so that we'd survive the Black Plague, or basically just surviving it. We didn't have the medicines at the time. And then as penicillin came about, probably one of the greatest discoveries in medicine that helped us to begin to survive as a species, okay, and survive these wars that we've had with this microbiology that's out there. Now we're in this paradigm of, now that we survive diseases and we can live and we have lots of medical treatments, we intervene at acute times of people's lives when they become sick. Well, being a public health physician as well, there's another frame of thought that we should begin to intervene over the course of their life course so that our efforts are more towards prevention and not reaction to a disease state that has become a process. So in considering that, we need to think about it in terms of when you yourself are an embryo, to when you yourself are a child, to then when you're a teenager and a young adult. So when a woman is in all these stages, we're only intervening here in prenatal care. But we know the Barker hypothesis tells us, come on guys, Barker hypothesis in one short phrase is around what concept? That's what I'm talking about. Fetal origins of adult disease. Absolutely. The fetal origins of adult disease. So what is happening when you yourself are in utero that your mom is being exposed to that is predisposing you to disease in the future? And then when you're a child, what are the environmental pollutions that you're around? Like I said, these could be chemical pollutions within the air, the soil, the water. These could be noise. This could be noise pollution. This could be unsafe environments, etc. This could be peer pressure, the people that you're around. So what are these problematic things in your environment that affect you as a child and affect your health outcomes? Because depression starts to develop in this area. Mental health, okay? And then also in your adulthood and young adulthood, we have 3 times of a woman's life. It's either before you become pregnant, if you ever will become a pregnant person, while you're pregnant, and then between or after pregnancy, so your interconception period. So when do we intervene? Again, in the prenatal period. But we should be focusing on interconception and preconception as a time to begin to intervene. So for those of you among the group that have had public health training, have you heard of the concept of perinatal periods of risk? This is something that that public health practitioners use to begin to understand fetal death or infant death in a way to understand where should we be intervening. So it's this interesting, complex, it's relatively simple to apply, but it has multiple factors, so it's comprehensive. And it begins to look at when did the death occur and what exactly happened around that death. And then it sort of points an arrow to tell you, should we be intervening on the neonate or should we be intervening on the mom? And that's been done in African American women populations. And what we found out is that we should be intervening on the mom. When we're intervening on the mom and making sure that the mom is as healthy as she can be before she becomes pregnant, that's preconception, interconception time, okay? So understand that when we're in clinic, you guys have often heard me say that though there are things that we can do in the prenatal period, we often can't really improve birth outcomes at that stage because it's a little bit too late, depending on what outcome we're talking about. But I'm talking about relating to premature birth and fetal death. When it comes to improving infectious disease transmission, such as HIV, that's been one of the most important public health interventions we've done in obstetrics to help reduce poor outcomes for the fetus and the infant, correct? So now we've helped to reduce the transmission rate of HIV, and that's been huge in the public health world. So talking about risk reduction and health promotion strategy. So getting back to what I'm talking about here, birth equity initiatives. So what are we thinking about and how we want to intervene? So I wanted to throw this slide out there to say there's a person in Neil Halfon who published this some time ago in the Milbank Quarterly that says, this is what our health development pretty much looks like. As we're born, our health status pretty much improves, and as we get older, it decreases a bit. It's not a difficult concept. And let's say an optimal trajectory is that it doesn't take any time for it to improve, but it just goes straight up and comes back down. So let's just say this gap here that exists between two people. What's the difference there? Well, risk factors lower someone's health trajectory. Protective factors increase it. So again, that concept of prevention. So let's apply this to birth outcomes. And so now I've designed this one. So let's take the reproductive potential of a black woman, and let's look at her as she herself is a neonate, a fetus. So I'll put age 0 here to show you. This is when she's in her mother's womb, so perinatal, during her childhood, her adolescence, and her young adulthood. So it does okay, but it's not great. Her reproductive potential is her fertility rate, her risks of having poor birth outcomes, her risks of having other problems in pregnancy being health-related to the mom, etc. This little bump here signifies prenatal care. So it improves a bit, because that's about the time we notice that a lot of women enter care, is in the prenatal period. Now let's take the reproductive function of a white woman. It's a lot higher, and it does pretty well into the young adult. So of course I don't have geriatrics in here, so it doesn't go down. So we're not going down at this stage. But what's the difference here? So again, risk factors keep you here. Protective factors bring you up. So what are those factors? What are some things that we think about for improving their health outcomes? Any ideas? Yeah, simple things. Dr. Delbovi just said exercise, appropriate nutrition, self-determination, so self-empowerment, feeling like you have some control over whether you become pregnant or not, birth control, understanding what that is, having an awareness, education, simple things of just simple health that women should understand. But there are other protective factors in the medical world that we're beginning to try and employ a bit better in our clinic and across our health centers. And what is that? Something I talk about often in spas, mini spas. So you guys have to throw it out there now. One, medication. It's a normal, natural, circulating steroid in your body. The placenta produces it. Come on. It's a progesterone. How many times do we talk about it in clinic? Does this person need progesterone? Have they had a previous premature birth? So there are other protective factors out there that we can try to use in medical world. So let me move forward and say that what we're trying to do is bring up African American women to the same reproductive potential. And again, I want to drive home this point. We don't want to simply intervene in the prenatal period. That in order to accomplish this, it has to happen over the life course. So let me recap. We've defined disparity with data to say that there is one, and that is across all levels, state, national, and local government levels of data reporting. We've understood that there are some issues related to premature birth and low birth weight, and why that happens we don't completely know, but we do think that there's a stress component to that, and how do we begin to intervene on this allostatic load. And when you do intervene on this woman, you need to do it over the course of a life course. So, that said, looking at differences in care, we also wondered, when you are pregnant, you deliver a baby, are you somewhere where your baby can get the appropriate NICU care that would help improve their outcomes? Well, there is not a difference in access to care that has accounted for the disparity, because even with increasing rates of access to care, we've still had an increasing, persistent disparity and increasing rates of premature birth. So we do know that with increasing rates of access to care. But differences in care received, there was a study that was done in New York that looked at the New York State Department's infant death rates, and what they were able to find out was that if some of these black women that delivered one particular hospital or set of hospitals simply delivered somewhere else, that would have reduced their infant death rate in the neonatal period by 400 deaths. It was a large group. And the reason is just simply that where most African American women live, especially those of disadvantaged backgrounds, they're delivering at hospitals that can't provide the appropriate care for these children at these gestational ages, because they may not be level 3 NICUs, etc. And then upon transfer, oftentimes it's a little bit later than what you'd like for helping the baby survive. So, in looking at the Institute of Medicine report, so there was a report called Unequal Treatment that was published in 2002 that talked about people of color receiving differences in care. So this isn't only related to birth outcomes. This is related to all health outcomes, that there are some differences in the health outcomes among people of color, either receiving lower quality of care when other factors are controlled, that they're rooted in historical and current inequities that occur on multiple levels. So that's the operative phrase here, multiple levels, because it's not just about intervening at where we provide health care as well. And conditions under which clinical encounters take place may result in care poorly matched to the needs and strengths of those certain patients. So we're talking about things like translators, okay? So how are we going to address the disparities? So I apologize that happened. So identifying the existing promising practice, creating the birth equity initiative, and applying this health equity matrix. Okay. So let's move quickly forward into that. I threw this up here so that you guys who are in the public health world would know where this model comes from. I can't do the job that I'm doing right now unless this is true. And because this is true, I'm doing the job that I'm doing right now. So Dr. Gary Gottlieb, who's the president of our hospital, instituted also the Center for Community Health Equity to look at health disparities. So there's the political will. He wanted us to have this as something that we're doing. It became a prevention priority. It was top of their list. How do we begin to reduce the disparity in infant death rates among the disparities in other places? Because they're also looking at cancer and they're also looking at cardiac disease. The social strategy. So we've got to do the data and the search to understand what do we do in the society to try to improve this. And the knowledge base. So we've got to use the available medical literature and evidence out there. Okay? And then once you put all this together, you've got the motor, the engine, the wheels, and everything to try to move this thing forward. But as you're moving it forward, we're starting to realize there's not a lot in the knowledge base. So a lot of it is stuff that we're going to have to help to create and study on our own. And the social strategy is pretty broad. So what are the specific things that we need to do to intervene became our question. So quickly, I'm going to push through some of this data because I have a lot more slides, but I'm going to fly through just to sort of give you a little bit of a data dump to show you some of the thoughts we've had. But quickly to talk about the Birth Equity Initiative, in February of 2008, we established this initiative to be a comprehensive, health-based, community-based initiative to eliminate that gap that I drove home in the beginning of this talk. We want to address the root causes of disparities via a clinical and community-based prevention system. So we're addressing premature birth and low birth weight, maternal cycle, social stress, and social determinants of health. We want to implement a life course framework over women's health and create community empowerment via enhancing social engagement and building social and political capital. So that seems easy enough, right? Then we'll go solve world hunger and move on. So the way we did is we began to identify the disparity in Boston and the root causes by neighborhood. We did a structured review of programs to look at who's been able to reduce the infant mortality rate, because the first thing we know is who else has done this and have they been successful. And so we looked for those programs. We found about 27 programs that did one of these three things. Most of them addressed stress. Some of them addressed social determinants of health, and some addressed healthcare quality improvement measures. And then we just made some phone calls. We interviewed some people. We called some programs and said, how did you design your program? What did you come up with? Who were the people that you were targeting, and how are you funded, etc. We just called, and we got a lot of information. Then we began to design our own program, the Birth Equity Initiative, which is evidence-based in the clinical component, the community component, and as far as our research agenda. So quickly, we looked at low birth weight over a decade in Boston by race, and again, we noticed that black race had the highest rates of low birth weight. We looked at the neighborhoods this way by low birth weight and infant death rates. We took the Boston low birth weight average and infant death rate average, and we looked at the neighborhoods who exceeded those, and those were North Dorchester, South Dorchester, and Roxbury. Not to say that Mattapan, who had a high low birth weight rate, and Hyde Park, which is starting to come up on both levels, we're not sort of negating those either. So we took all those together. We looked at it again across the decade at low birth weight rates, and we saw the same neighborhoods pop up. So we thought, okay, let's focus just on those neighborhoods. So we looked at low birth weight births in Boston by each neighborhood, and we saw that certain areas of Grove Hall, Upham's Corner, had higher rates. So I'm sorry I'm moving fast for some of these. We took those same neighborhoods and looked at it by race. We looked at it by low birth weights in each neighborhood in terms of the type of low birth weight. The important part here is that if we're saying that death is death in the neonatal period, the first 28 days of life, we're talking usually extreme and very low birth weight births, not the late preterm births that are accounting for that rise of prematurity across the country. So when it comes to the infant mortality period, we're talking about those babies that are very and extreme low birth weight births. So you see these numbers here in very extreme low birth weight and then general low birth weight, so between 1,500 grams and 2,500 grams. If you do that just by black birth, you see that these numbers here aren't changing very much. So it just shows you that that's because most of these are being accounted for by black women. We then took the birth analysis and decided just to look at Brigham alone. So I was talking about Boston before. Now we're just doing Brigham. So I'm going to, again, move a little quickly through this. We looked at it by prenatal care site. So this is the faculty service, and this is us in the OBS service. We looked at their low birth weight rates. We looked at it by race. But this is a little bit difficult because we get a lot of other and unknown. We looked at it by language. We looked at it by in-hospital infant deaths. And I want to sit this slide here for a second and say, what do you guys notice about this? We've been talking about a disparity in infant death. But do you see anything interesting about this slide? Yeah, first of all, the numbers are really low. This is for 26 deaths over this 1 year. So that doesn't get, so it sort of skews the graph a little bit. The overall rate was 1.7. Unknown and missing was definitely higher. Hispanic was higher, and this is, again, mostly likely pointing towards a Puerto Rican population, but that's still to be determined. But there's not really much of a disparity here. So there is an interesting and very important concept that's out there in the disparities world right now, and that is when you find a health disparity, is that disparity seen within hospitals, so populations that present to certain hospitals, or between hospitals? Where is the disparity? So really within the Brigham so far, we haven't in this, and we've just looked at these first few deaths, and we're collecting more information because these are only in hospital. Because of the postnatal deaths that happen, we don't have record of that. That's through the Mass Department of Public Health, so we're getting that information. It's a slower IRB process. But with that said, we don't really see a disparity within the hospital. And that's mostly because of the type of services that we can provide as practitioners to the mom and as far as our NICU care. So, but there is a disparity within the city, and so we still are sort of on the search to understand how that disparity is created and where it exactly exists. And then we thought, let's just take it down to simple numbers. You know, when people do public health media presentations and campaigns, they usually pick a number. Like, so the breast cancer number was the 1 in 8, and that was always flashing on television ads. So what's our number going to be? We need a number, right? So we thought, what does it take to achieve birth equity here? So if you take the white infant mortality rate at 3.5, this is a 3-year average, because most public health reporting reports in 3-year averages. And we prevent 12 deaths annually, sustainably. We've dropped it down to 5.2. If we prevent 17 deaths annually, sustainably, we've eliminated disparity in the city. So this is across all hospitals, 17 deaths annually in the city. That's neonatal and postnatal deaths, so that's including the whole group. But if we target the neonatal, you're targeting the underbelly, because that's the excess deaths there. And then also, how many low birth weight births is that? Well, that means we've got to prevent 152 extreme and very low birth weight births to bring down the rate. It's a little bit different, doesn't it? Changes tunes when we say that, because we don't know who those people are going to be when they come through the door, of course. So, again, I went through the steps of saying we identified the disparity in Boston. We did the structured review to look at programs, then we began to design our own. So I'm going to move forward quickly into saying that we have a clinical strategy, a community strategy, a health system strategy, and a research strategy. This is the matrix that I'll spend just a minute or two on, and then we'll close out. This health equity matrix is the combination of two thoughts. I wrote here that I adapted this from Michael Liu, his life course approach, and Kamara Jones, her levels of intervention. And this is from their PBS broadcast, The Natural Causes. I don't know if you guys saw that or if it was advertised that it was coming out. So Unnatural Causes is something that the Harvard School of Public Health in conjunction with others produced and showed on PBS in a 4-part series. One of the parts was called When the Bow Breaks, and that talked about infant death and infant mortality. And they talk about levels of intervention. So remember we said that this had to be addressed on multiple levels. So these levels include primary, so addressing social determinants of health, and that includes issues around improving living conditions and jobs. Second level being clinical and community level of intervention, so that means addressing health behaviors, so programs related to nutrition, child health education, et cetera, breastfeeding. And then tertiary is what happens in the clinical care, so addressing quality of medical care and availability, access to medical care, et cetera. So this, I'm an 80s kid, so we use a Rubik's Cube design to show this. So this is basically what, this matrix you are applying to the target population. So you apply this matrix to a population of black women in Boston, and you offer them services at each level. Over each year of the program, over their life course. And when you do that, this explains what's happening. So if a person comes in, they're in the medical care, they're pregnant, so this is before their baby's born, so the before birth refers to their child. What are we offering? So, for instance, when they come in and they're pregnant, we can talk about prenatal housing programs. And the way we do the research is we measure their housing instability and their environmental safety. You can do that through surveys, et cetera. So we've already begun to work on something like this with the Boston Public Health Commission. We've got a strong collaboration with them. We talked about things like if we have housing available for women when they're pregnant, when we can't find them sometimes when they're coming into clinic, and then you guys have called and you can't find them after that. Sometimes these women don't live anywhere. They're homeless. So if there's a housing program, if there's a way for them to be reached, then that's something that you can begin to measure to see if this has an impact on the outcome being low birth weight birth and infant death. So the second level, so now we're talking about preventive strategies where community meets medical care. We're talking about nutrition, simple things. Measuring the utilization of nutrition services in the hospital or a program within the community. And you can do surveys to measure maternal behaviors for improved nutrition, and then you see how maternal behaviors affect the outcome. And then tertiary, our progesterone therapy. So we want to look at the availability and use of progesterone in Brigham health centers, and we want to measure the results of the interventions of the short cervix, for instance, in our clinic, and we want to look at whether or not those things have a direct effect on the outcome. So just to say a quick note again about progesterone. So after the publication of 2 large trials, ACOG put out the committee opinion that I posted in every one of the offices. You guys have seen it, right? In 2003, ACOG committee opinion said that we want to provide progesterone for patients with a history of premature birth. So someone that delivered between 24 and 36 weeks of gestation, so before 37 completed weeks of gestation, in a previous pregnancy due to preterm labor, spontaneous preterm labor, and that included, those groups included PPROM, so rupture of membranes. If they have a history of that, then in their next pregnancy you want to provide them with progesterone therapy. That's the intramuscular 250 milligrams IM Q week, so that you can help reduce their risk of another premature birth. That risk reduction is about 30%. So places that have seen a good risk reduction, that they've been able to implement this, you're going to think it's going to have to be the smallest places, right? So some places like Delaware, the state of Delaware has done a good job of implementing that across their state. They've seen a reduction in their low birth weight rates. So we want to measure those things. So this is the heart of the Birth Equity Initiative. This is what we want to offer our population so that we can try to improve their birth outcomes. So again, just a bit on the clinical agenda, we have a community agenda, research focus. And some of our current projects include looking at progesterone. We're beginning a project looking at cognitive behavioral therapy interventions, so short interventions during the prenatal period on depression and stress and whether or not that affects the birth outcomes. We are also doing GIS mapping to understand neighborhood conditions related to infant death. And we've done some survey studies, to understand if women in the community are aware of infant mortality and the disparity and their attitudes toward nutrition and reproductive life plans. So understanding that they have a choice of when they want to conceive and that they should implement whatever measures it takes, whether it be abstinence or other measures of birth control, to control when they're going to deliver and when they're going to be pregnant. We do know that interconception periods, so expanding that greater than 6 months, so anyone that's had a baby that gets pregnant and delivers again within 6 months are at higher risk of having a premature birth. We want these longer interconception periods. So again, whether that be abstinence, whether that be other measures of birth control, keeping these women in the healthcare system and not seeing them just 6 weeks after having a baby, but seeing them again and not getting them lost out of the community to come back pregnant again is what we're trying to intervene and do. These are some of the outcome measures that I just threw together in a quick slide. In case someone asks some questions, I can point to some specifics about that. And on our last slide, I want to talk a little bit about the cost savings that we would have. So cost of premature birth. So estimated, looking at me, not at the screen, how many births do we have in this country a year approximately? Okay, look at the screen. So about 4 million every year we have births in this country. It costs us about $52 billion for this as annual healthcare costs. And this is taken from workforce data, actually. So this is from health plans paying in because of workforce. And this is in combination of workforce data and CMS, so Center for Medicaid and Medicare Services. So the total cost of babies born prematurely, we have about a 13% premature birth rate, and that's about 500,000 babies. So that's about $26 billion. About half of what we spend on births goes towards this 13%. So the cost of a baby born healthy, about $4,500 out of a health plan. Okay, this is not out-of-pocket expenses. but the cost of a baby born prematurely, about $50,000. It's a cost savings. So we're looking at that as well. So that's something else we want to try and measure over the course of whether any of these programs, each specific intervention, would help improve the outcome. But it takes intervention at multiple levels together to solve this Rubik's Cube. It's been very difficult. It's something that people have been trying to look at for decades, and it hasn't completely been solved because you see that disparity's been present as a gap for years. But if we can begin to put the colors together and make the Rubik's Cube make sense, then maybe we can get closer to reducing the gap. Thank you. Take 2 questions.
Just a comment. I think that stress reduction works to a certain extent across all medical problems.
Sure.
Number one, almost every study has a 30% placebo improvement rate.
Sure.
And what is that? Maybe that somebody cares about you.
Mm-hmm.
When I was a resident, there was a study where just sending somebody to somebody's house improved the growth rate.
Yeah.
So that's, what is it? It wasn't a doctor. It was somebody who cared about you.
Yeah, home visitation programs have been tried to be measured, but people don't do a really good job of it because what happens often is we get these policies that say let's improve a health outcome. We get money from a federal, state, or local level to create a home visitation program, and then what happens? You only have enough money to pay the home visitors, but you don't have money to pay for someone to evaluate the program. So oftentimes we don't have information on that, but we've definitely seen some improvements from anecdote from that.
I don't actually, and maybe I'm just naive, but I don't really understand why the Latino and the Black population is so different.
The Hispanic paradox has a lot of information to it. Some people said that one of them is sort of the healthy immigrant effect, that people who are the sickest don't come over, and as far as, so in terms of their birth outcomes, we're not seeing worse birth outcomes. And then some people said that before you're going to see a lot of cardiovascular disease, they've gone back to their country to die, so it's not getting reported in our system. That's been dispelled, so we know that that's not the case. And then we looked at it, some other people have looked at it a little closer and further. And right now the ongoing thought is resiliency and social connectedness. So
some of the community stresses are similar, but yet.
Absolutely. So they're same levels of low income, education, et cetera, and they have better birth outcomes. And there's some information pointing to the fact that they have more of a sense of community, either protected by language, by a social societal, social cohesiveness that might be there, and that's difficult to measure.
Yeah, but you wonder if that may be an intervention.
Exactly.
That's the disparity most likely.
Mm-hmm.
In the different cultures that were represented, one of the things that I noticed, besides for the Hispanics being low, the Asians being the lowest. And those are two communities where family and support are the most important.